antibiotics and giving the last line antibiotics like paracetamol, and so long as you have the capacity to do. Next one is medicine information. So many people are not aware of pain spaces arising for irrational medicine use, and our market is filled with substandard and counted product all over the place. Many in Abuja, you see people in basket selling medicine without any formal training on how to use medicine. The last one is limited antimicrobial stewardship in our hospitals. This will be as a result of lack of experience health personnel, coupled with the fact that so many experienced ones are living the country. So what prescription today is resources tomorrow. Antimicrobial resistance is driven by prescribing behaviors. Antimicrobial resistance is a situation where microorganisms, the drugs that we use to treat microorganisms such as bacteria, fungi, microsis, will block resistance to the drugs that we used previously to treat them. And that results in what? Antimicrobial resistance. The two main drivers of antimicrobial resistance are inappropriate use and overconsumption. One funny thing about antimicrobial resistance is that whether you use antibiotics rationally or irrationally, it encourages resistance. But it is more common with irrational use. Another one is, for instance, the use of antibiotics to treat viral infection. You just have simple cough caused by viruses. You go and take augmentin. Extended prophylaxis. Surgical prophylaxis ideally should not go beyond 24 hours. At most 2 doses. But you will see people you see patients with clean surgeries will be left on antibiotics for weeks. Extended unnecessary broad spectrum also encourages antimicrobial resistance. So let us quickly look at 2 clinical scenarios. These are 2 patients with the same diagnosis, but they went to 2 different healthcare facilities. The first one received treatment based on available evidence guideline from the established national guideline, and he recovered fully with minimal cost and no complications. Well, the other one went to a facility where they don't have business adhering to the national guideline. He was treated, he received multiple medications, including antibiotics and adjustment supplements, and he ended up having adverse drug reactions, his illness got prolonged, and he incurred additional cost. So if I were to ask you, if you have a patient, which of your facilities will you want your patient, will you want to take your patient? I'm sure you will tell me that you would like to take your patient to a facility attended by what? By patient E. So now the difference is not about the disease, it's about the quality of prescribing. So I would like to urge my fellow prescribers to always prescribe with purpose. Before writing any prescription as a clinician, please ask yourself these 5 questions. Is this medicine necessary? Is the diagnosis correct? Is the guideline available to treat this patient? Is there a simple alternative? Maybe you have option to use either Birnin or attachment. Will the patient adhere to it? Because if you are prescribing a very expensive medicine, maybe if you are retired or somebody who is earning minimum wage, the rest assured he is not going to get that medicine. So we are now going to look at prescribing cycle. Rational prescribing is a continuous process, and it starts with what? Accurate diagnosis. And to make an accurate diagnosis, you need to what? To make an accurate diagnosis, you need to assess your patient by taking good history, doing general physical examination and relevant systemic examination. That will help you to establish an accurate diagnosis. Having established an accurate diagnosis, the next thing is to establish therapeutic objectives. Then look for evidence-based guideline. That is where you can prescribe. So you can see writing a prescription is even stage number 5. After you have written a prescription, the next thing is to counsel your patient on adherence and how to use medicine. Then monitor and follow up. If it is on admission, ideally after 1 or 2 days, we need to go and monitor and see how they are doing. If there is need to review the treatment, then you will do that. Considering the importance attached to rational medicine use, the World Health Organization in 2001 developed 12 core interventions to assist prescribers in rational medicine use, and they ranges from problem-based pharmacotherapy. So if you are teaching medical students or other healthcare science students, you should utilize problem-based learning to teach them. Continuous professional education, my Oga at the top, they are doing their best. It is just that these days, so many of us are not attending that. Then prescription audit and feedback. The Antimicrobial Stewardship Committee in a hospital called Drug and Therapeutic Monitoring Committee are saddled with the responsibility of going to to audit the prescription of doctors, right? And give them meaningful feedback that will improve prescribing. Then public education, essential medicine list, clinical guidelines. What the WHO advises is not to use this intervention in silo, but rather to use them in combination. That is when you will get the maximum benefit from them. Next one is measuring rational medicine use. As the saying goes, what gets measured gets improved. If you cannot measure it, you cannot improve it. Our main problem in this country is that we don't measure anything. In instances where we do the measurement, we don't use the data to inform our policies. So, World Health Organization, in collaboration with International Network for Rational Use of Drug, provided us with standardized indicators to assess the quality of prescribing, quality of care we are giving to the patient, and then the facility performance. We don't have enough time to go through all these indicators, but what I would like to see is that for you to improve the quality of prescribing in your hospital, you have to monitor the prescription indices. Next one is very important committee, drug therapeutic committees. These committees are the one responsible for driving costs behind rational medicine use in hospitals. And ideally, every tertiary hospital should have this committee. And the committee should have multidisciplinary members from physicians to pharmacists to lab scientists, to hospital administrators who are going to give mandate and power to the committee members to observe their duties. And I'm glad to tell you that this very hospital has got one, and I think it is very effective because I worked with them, I think about 2 or 3 years ago. Part of their mandate is to develop and implement drug formulary that is aligned with the essential medicine list. They should also monitor antimicrobial use, conduct prescription audits, and prevent medication error. They are also saddled with the responsibility of organizing training and workshop to healthcare providers in the hospital. Next one is antimicrobial stewardship. Antimicrobial stewardship is one of the most effective strategy that is used to improve rational medicine use, and it is defined as a coordinated set of interventions to improve antimicrobial use by promoting the selection of the right antibiotics at the right dose, right duration, and the right mode of administration. Antimicrobial stewardship improve patient outcome and safety, reduce antimicrobial resistance, and reduce the chances of developing complications. My entire postgraduate journey was in antimicrobial stewardship from master's to PhD. In 2017, the World Health Organization also introduced another concept of aware classification of antibiotics to improve antimicrobial stewardship. So what the WHO did was it categorizes antibiotics into 3 categories. We have the access, we have the watch, and we have the observe. The access access are mostly narrow-spectrum antibiotics. These antibiotics, there is the use of these antibiotics has got very limited chances of resulting in what? Antimicrobial resistance. And they include drugs such as fluoxetine, ampicillin, all those area generation of penicillins and cephalosporins. While the watch category, they have got an extended spectrum. They have effect on what are positive, gram negative. And what the WHO said, if you are using this one, you should be much mindful of what you are using. So you should be watchful. Because there is higher tendency that use can encourage resistance. They include drugs such as augmentin, sprofloxacin, all those used for they are commonly used in our hospital. Well, the last one is reserve. Reserve category. These ones are the last line or last resort antibiotics. And ideally in the hospital, they should be kept under lock and key. Whether you are a professor, you are a very senior consultant, you cannot just write holistic. You cannot just write anything, vancomycin or European. You have to go to maybe drug therapeutic committee. They will review your application before they review. If there is rationale for using the consent using. So what I really recommend is that the national antibiotic consumption or a facility consumption, 60% of which should be within accessible. So if you do an audit and you discover that most of the drugs you are prescribing are from watch or reserve group, you should know that you are not doing the right thing. And you need to institute an intervention. Next one, I want to see this one, SMART framework. This SMART framework has what 5 dimensions. Prescribing should be safe, prescribing should be measurable, prescribing should be affordable, it should be rational, aligned what? To an evidence-based guideline, and it should be timely. Does artificial intelligence has any role to play in encouraging rational medicine use? Yes, it has. It can assist us in making clinical decisions, it can flag allergies, it can encourage rational prescribing. You know what one of the different things between rational prescribing and manual prescribing can do away with a lot of errors and a lot of other useful impact. However, my advice is that even though artificial intelligence and technology can improve rational medicine use, please, it should be what? It should just be complementary. It shouldn't replace clinical judgment. I'm going to skip this one. The role of pharmacists. I'm just being reminded that my time is going. So, pharmacists, they play a very important role in ensuring rational medicine use, ranging from ensuring appropriate dispensing to providing counseling to the patient. I will move to the role of other healthcare professional doctors. They are the ones to make diagnosis and prescribe by adhering to available evidence-based guidelines. Nurses, they administer medicine safely and monitor side effects. Laboratory professionals, they also have got a role to play by assisting us in making microbial microscopic culture and sensitivity to encourage evidence-based practice. University has got an important role to ensure what rational drug use by ensuring that every graduate coming from their institution is not just competent, but is what is competent in prescribing. So I'm going to move to the next slide. Government is the mother of all, and government is saddled with the responsibility of providing an enabling environment for us to prescribe responsibly. So as a society, we have got a role to play. Everybody has got a role to play in ensuring rational medicine use. Patients should use their medicine responsibly as prescribed. Community should promote rational medicine by promoting medicine awareness and ethical practices. So this is my vision for Nigeria by 2050. I would like to see a Nigeria where every prescription is evidence-based,
every patient is informed about dangers of irrational medicine use. Every hospital has antimicrobial situation program, and I think it is achievable. So allow me to leave you with 4 key messages. Firstly, every prescription is a public health intervention. Evidence should guide our prescribing and not just have it for what we see our seniors are doing. Antimicrobial stewardship protect medicine for future generation. Education, regulation, and collaboration are also essential. This is my pledge, and I urge you to make me, I urge each and every one of you to promise to our patients, nation, and profession that I will prescribe with purpose, I will use medicine with care, and I will support smart choices of these precious resources. So I would like to end my talk with a very important quote from the former Chief Medical Officer of the United Kingdom, Sir Liam Donaldson. He said, every antibiotic expected by a patient, every unnecessary prescription written by a doctor, every uncompleted course of antibiotics, and every inappropriate or unnecessary use in animal or agriculture is potentially signing a death warrant for a future patient. I would like to acknowledge the support I received from the Federal University of Kebbi, and I would like to also acknowledge the support I received from medical students from their classmates, Abdul Bashar, Anas, Aisha, Umar, Kebbi, and Umar. And I would like to acknowledge everybody that has got time to come and attend this public awareness lecture. Thank you so much.
Thank you very much. We want to sincerely appreciate Dr. Bashar Mohmmed, the acting dean faculty of basic clinical sciences, for this wonderful lecture. We really have the courage. We sincerely appreciate your motivation to give us this intervention. It's very glad to see that we are thinking there's something for everybody, whether you are a student, whether you are a teacher, whether you are just an ordinary citizen, whether you are a lecturer, whether you work in the hospital, whether you are in the university, whether you are a policy maker, is being able to speak to all of us. And I believe if we have been taking notes, there's really key messages that we need to go on with. Let me say, while he was delivering his lecture, we have the honor to receive Professor Aliyu Silent welcome. Registrar of the university, Barrister Hamza is also with us. Thank you very much. One of the most senior professors, my personal boss, Professor Aisha. The next 10-15 minutes is actually for interactive session. We're going to attend questions and comments. For suffice is to say, we have listened and we have listened very well. Medicines are used rationally. If you use them rationally, there is evidence. But when you choose to use medicines rationally, there is definitely going to be a harm. And everybody has a role to play. We sincerely thank you and appreciate you. For the next 15 minutes, if you can entertain questions and comments, please recognize yourself so that we can listen to you. High table, university community. Okay, the BBC wants to speak. Can I recognize him, or we should have more hands? We should have the BBC. Okay, BBC, please.
Thank you very much. First of all, my apologies for coming late. My question is on the issue of this irrational use of drugs, not only antibiotics, maybe in general. So what is the way forward? How can we stop that? How can we create awareness to the human people that you don't know anything about drugs. They take drugs anyhow. You see, if you go to living markets, you see a lot of drug barriers. They go with the drugs. Even the safety of the environment where these drugs are kept is a question. That's my question. Thank you.
I'm sure we think the question about the tough one, but I believe the presenter will do justice to this question. Please. Thank you very much. That's really quite thought-provoking, because when you now impose the plan, then how do you ensure compliance? That's another aspect.
First of all, I want to appreciate the lecturer for the thought-provoking presentation. It's quite imperative that we should have many of these ones, especially in our hospital settings, in our CPDs. Though he has presented once, I think we need to have more, especially since our doctors on this rational use of antibiotics. And as rightly said by the WHO, there are funds there that I think are yet tapped from the WHO concerning this microbial resistance and stewardship, which I think we need to explore from there. Thank you.
So that is why it's good to always recognize the policy makers, because they are now opening our eyes so that we can see better. We need to really collaborate with the WHO and see which resources we can tap, because there are many takeaways from here. Institutions will definitely benefit, not only entities, but even the government as a whole. So we will still recognize 2 more. Okay, all right. How many more should we recognize? All right, we will recognize 4. And out of these 4, we will make sure that students are also recognized. And there should also be gender equality. Or is it equity? Prof, I think you raised your hand.